I'm a mental health nurse with experience working on a PQ, acute, forensic and crisis care services. I also have my own lived experience. I would define sexual safety as a person's right to feel and be kept safe from sexual harm. Psychological and physical safety are the prerequisites for healing and recovery to take place. The feeling of safety is unique to the individual, so we have to work with that person to find out what it means to them. Sexual safety also means the duty of caregivers to protect those that are vulnerable from sexual incidents on our wards and to respond appropriately if an incident does take place. It is about creating a culture where a person feels and is able to speak up and know that steps will be taken to keep them safe from further harm. Sexual safety is important to women and those that identify as women because at any one time 50% or more on an inpatient ward has survived previous sexual assault or abuse. Hospitals should be a place that promotes recovery, but instead many of our women are re-traumatised by a lack of understanding around the trauma response and triggers acknowledgement of the impact of restraint, enhanced observations on mixed-sex wards. Sexual safety incidents themselves are relatively rare, but they do occur, and we also need to increase awareness of iatrogenic trauma, acknowledging that what we may see as helping a patient they may experience as harm. It's also about supporting women to come to terms to understand what happened to them and that it was never their fault, and how responses may have contributed to or be diagnosed in the form of mental health difficulties. I support sexual safety by working with key stakeholders, service users, sexual violence and sexual health organisations to champion change. I encourage other professionals to overcome personal barriers that prevent them from talking to patients about sexual violence and sexual safety. We need to put our professional obligations above any personal discomfort. I also work to ensure that staff, students, service users have information and education around sexual health, sexual violence, sexual orientation or sexual expression in a way that is accessible to them. 5. Take-home messages. 1. Acknowledge that a perpetrator could be another service user, a partner, a relative. It could be a colleague, or in the case of iatrogenic trauma, it could be you. 2. Assume trauma. A person should not need to disclose a previous experience for you to have conversations around preferences of key worker, staff on observations, whether they are nursed in a single or mixed sex environment, and how, if as a last resort, they need to be therapeutically held, restrained, or given medication against their will, how this can be done in a way that causes the least harm. 3. Know your local services, independent sexual violence advisors, domestic violence charities, victim support organisations, the police, local safeguarding boards, sexual assault referral centres. Make sure your colleagues and your patients know of them too. 4. Work to make any strategy inclusive. Minority groups have unique needs that place them at higher risk and less able to disclose sexual violence. Take into account the needs of persons from Black, Asian, minority ethnic backgrounds, religious and cultural needs, sexual orientation, or if a person is transgender or transitioning. Also consider those that have learning difficulties or other communication needs. It's our responsibility to keep all people safe from harm and create the conditions in which all people are able to speak out if they do not feel safe and know that they will be fully supported in the response to any disclosure that they may make. Number 5. Sexual safety is everyone's business: staff, service users, statutory services, and societies. The three most important words that you can give and a person can hear if they become affected by sexual violence are, "I believe you."